Hey everyone, welcome to this explainer. Today we're going to take those dense, dry clinical notes and literally transform them into a high-yield study guide. Think of this as a memorable rogues gallery of pathogens, specifically focusing on the Vibrio species. If you want to master the core pathophysiology, the key diagnostic markers, and the clinical presentations of these dangerous bugs without getting lost in the textbook weeds, you are in the exact right place.
Okay, let's dive right into this because this is honestly one of the most fascinating physiological paradoxes in all of medicine. Imagine a pathogen that can literally drain up to 250 milliliters per kilogram of fluid from your body in a single day. That's massive. Yet its ultimate defeat comes down to simple sugar water. How is that even possible? Well, answering that exact question unlocks the entire mechanism of our primary suspect today.
So here's our game plan. First, we'll look at the mastermind, cholera. Second, the biochemical heist and ORS. Third, the wound maker, vulnificus. Fourth, some seafood suspects. And fifth, we'll wrap up with a high-yield Vibrio matrix.
All right, section 1, the mastermind, cholera.
So when you're trying to ID this mastermind on the words or, for your exams, you need its exact diagnostic fingerprints. Vibrio cholerae is a gram-negative curved rod, and it's highly motile. But you've got to burn these specific markers into your brain. It's oxidase positive, and it's selectively cultured on TCBS agar. That stands for thiosulfate, citrate, bile salts, sucrose. Also, while there are a ton of strains out there, epidemic potential is strictly limited to just the O1 and O139 serogroups. Actually, the current 7th pandemic, that's driven by the O1 LTOR biotype.
Now, what's really interesting about this is the classic clinical presentation. Cholera causes explosive, painless, watery diarrhea. You're going to hear it called rice water stool, kind of gray, slightly cloudy, with these little flecks of mucus and a distinct fishy odor. But look at what's absolutely missing here. No blood and no fever. It's crucial to remember this is a purely secretory process, right? Not an inflammatory, tissue-destroying one.
And here's a super fascinating patient risk factor to keep in your back pocket. Having blood group O actually puts a patient at the highest risk for severe cholera. On the flip side, blood group AB carries the lowest risk. And another quick thing, because this bug is super sensitive to stomach acid, any condition that drops gastric acidity, like just taking everyday antacids, actually skyrockets a person's susceptibility.
Moving on to section 2, the biochemical heist and ORS.
You see, cholera doesn't just smash its way into the intestinal wall, it's way sneakier. It sends in a specialized tool. The cholera toxin has an enzymatic A subunit and a binding B5 pentamer. Think of it like a heist. Step 1, the B pentamer acts exactly like a key, binding right to the GM1 ganglioside receptor on your intestinal epithelial cells. Step 2, this lets the A subunit slip inside where it ADP ribosylates a G protein. Basically, it permanently jams the cellular adenylate cyclase alarm in the on position. Step 3, this massively ramps up intracellular cyclic AMP. And finally, step 4, that huge surge in cyclic AMP completely blocks sodium absorption and kicks chloride secretion into overdrive.
And this brilliantly illustrates the resulting chaos. The toxin is manipulating two totally different cell types at the exact same time. Over on the left, in the crypt cells, it's forcing the active secretion of chloride. Then on the right, in the villus cells, it's completely shutting down the absorption of sodium. So what's the result? Sodium chloride just builds up in the intestinal lumen, and water aggressively follows it via osmosis. Bam! Massive secretory diarrhea.
But wait, here is the answer to that crazy paradox we talked about at the very beginning. As catastrophic as this toxin is, the sodium-glucose cotransporter, it remains completely intact. It's totally unaffected by the cyclic AMP surge. That right there is the absolute critical vulnerability of the cholera pathogen. Which leads us to oral rehydration therapy, or ORS. It exploits this exact loophole. By giving a patient a simple solution of glucose and sodium together, that intact cotransporter grabs both molecules and pulls them right into the villus cells. And water? It just passively follows along. This reverses the dehydration even while the cholera toxin is still doing its thing. It's a really simple physiological trick, but it's a literal lifesaver globally. Fun fact, rice-based ORS is actually superior to standard ORS because it delivers that glucose even more effectively. Okay, let's move to section 3 and see how this builds. The wound maker, vulnificus. The contrast between our mastermind, cholera, and our wound maker, vulnificus, is absolutely high yield for your clinical mastery. When you're out on the wards, remember this stark difference. Where cholera gives you that watery diarrhea with absolutely zero fever, vulnificus hits completely differently. We're talking hemorrhagia, bullous skin lesions, profound sepsis, and leukopenia, which means a dangerously low white blood cell count rather than the elevated one you might normally expect. Now, you absolutely must associate vulnificus with two primary clinical syndromes. The first is primary sepsis, and this overwhelmingly strikes patients who have underlying liver disease or hemochromatosis. Why? Because iron overload exponentially increases the virulence of this bug. It thrives on it. The second syndrome is primary wound infection, usually from direct contact with contaminated seawater. But in either scenario, the treatment requires urgent, aggressive action. We're talking immediate wound debridement and a heavy-hitting combo of ceftazidime plus doxycycline. So the crucial point here is this absolutely staggering number, 50%. That is the mortality rate of vulnificus primary sepsis if it isn't caught and treated promptly with aggressive antibiotics and debridement. Half of the patients. This is the detail that will literally save someone's life. It is an absolute medical emergency. All right, section 4, let's look at the seafood suspects. Meet Vibrio parahemolyticus. This guy is the leading cause of seafood-borne bacterial enteritis worldwide. It's notoriously linked to eating raw or undercooked seafood, especially over in Japan. Its main calling card? A virulence factor called thermostable direct hemolysin, or TDH for short. Now, unlike cholera, this bug can cause either watery diarrhea or a bloody mucoid dysentery. Thankfully, it's usually self-limiting, but severe cases are going to need fluids and antibiotics like doxycycline. Then we have Vibrio alginolyticus. From a diagnostic standpoint, this is the most salt-tolerant species of the whole group. It can actually survive in greater than 10% sodium chloride. You'll usually see this one linked to beach and seawater exposure. It causes more localized issues like otitis media in the ear, conjunctivitis in the eye, or mild wound infections. Luckily, it's generally pretty mild and responds super well to tetracycline. And finally, section 5, the high-yield Vibrio matrix. Okay, prepare to take a mental screenshot here because we're pulling all of these culprits together into one high-yield matrix. Let's rapid fire through this to really lock it in. First, V. cholerae, causes cholera. Look for that rice water stool and GM1 ganglioside binding. Treat primarily with ORS and azithromycin. Next, V. vulnificus, causes sepsis and wound infections. Keep an eye out for hemorrhagic bulli and high risk in iron-overloaded patients, and treat it aggressively with ceftazime and doxycycline. Then, V. parahemolyticus causes gastroenteritis, driven by that TDH toxin from undercooked seafood, mainly treated with supportive fluids. And lastly, V. alginolyticus causes local ear and wound infections, stands out as the most salt-tolerant Vibrio, and is easily treated with tetracycline. Got all that? As we close out this explainer today, I want to leave you with a really fascinating epidemiological thought. So we know the 7th cholera pandemic is currently driven by the L-Tor biotype, which originated way back in 1961. But bacteria, they're master adapters, right? With ocean temperatures shifting globally and pathogen evolution constantly ticking forward, what specific adaptations might drive the 8th pandemic? It's a question that keeps infectious disease experts totally on their toes, and hopefully it keeps you curious too. Thanks so much for diving into this study guide with me. Keep learning, keep questioning, and I'll catch you in the next explainer.